We're going to move on to the final two themes in Jean-Louis' 4 building blocks for making improvement. We'll begin with theme 3, which we've entitled Changing the Center of Gravity, Primary Care Leading Health Improvement. And I'd like to invite Sarah Newberry to come and speak to that. Thank you.
First, thank you so much for the invitation to be here with you today. It really is both a pleasure and a privilege, and it's been a wonderful day so far. I feel, as you'll see a few slides from now, that having my presentation follow Mount Sinai's presentation really does feel like it's changing the center of gravity. Now's this. I'm going to put a plug in for one person, one clicker as well. There we go. So we'll touch on a few things today. I'm going to begin by talking about the importance of place, because I think place really does matter in the context of primary care and healthcare overall. I'm going to talk a little bit about why primary care, about our current context, particularly in the province of Ontario, and a little bit about the way forward. I want to start really by reminding us that health is in fact a very local phenomenon. This is the importance of region in the conversation about regional governance. Health is driven by things like availability of employment, clean water, safe schools, recreation, all of those kinds of things that are local phenomena within communities. Health care is also a very local experience. And I want to share with you that from my experience living in remote Northern Ontario, that people make their health decisions often not based on what that care entails, but in fact on where they can receive that care. So we have patients in our practice who choose not to have dialysis or radiation therapy because that would mean several weeks and sometimes a permanent move away from home, which they're not willing to undertake. Rural patients, we know, perceive surgical risk differently, and they are willing to accept a higher degree of risk in order to receive care close to where they live. Women make decisions about where they give birth, despite our perceptions of the risk of that decision, because they want to be where they are known and loved. And certainly at the other end of the spectrum, people choose to die where they have lived their lives. So I think it's important that we remember how local healthcare is. Healthcare systems are also very local. To follow Mount Sinai's talk and let you know that my LHIN actually covers 47% of the province's geography and holds only 2% of the province's population. We have very limited tertiary level services and certainly no quaternary level services. We have lower life expectancy, in fact, by 5 years compared to the best performing LHIN in the province. We have higher rates of smoking, inactivity, and obesity than almost every other LHIN, and we have low rates of primary care provider attachment, largely because of historical inequities in primary care provider resource that has been the legacy of many northern and rural places. So I think when we think about equitable access to primary care and equitable access to healthcare service overall, that's kind of the why question. Why are we doing this? Clinical governance, I think, can help answer the how question. How do we take what it is that we're meant to do and apply it in a local context, adapt it in a way that's meaningful for the setting in which care is delivered? So this map actually gives you a little bit of a sense of the geography. I don't know if you can see the little blue push pin that is Marathon. Just off on the bottom right corner of this slide is Sault Ste. Marie. I think it's the top left for you, just above the white line that is the Minnesota-Ontario border, is Thunder Bay. That north shore of Lake Superior is actually 700 kilometers of highway. And you'll note that in addition to the blue push pin at Marathon, there are actually only 3 other white dots on that map: Wawa, Terrace Bay Scriber, and Nipigon. 700 kilometers with only 4 places that you can access primary care or local hospital services. This is the context very different from the downtown Toronto Sinai context, but it is a context in which we have to assure ourselves that we can deliver equitable care for the population. So the next question to me is, why lead this conversation with primary care? And to me, the answer to that question is that if the region is one integrator, as was clearly presented today in Dr. Bergevin's paper, then primary care is the other key integrator of the system. This is an ecology of care slide I've lifted from the Canadian Family Physician Journal in 2015. You probably can't see the numbers or the references, but I'll walk you through it a bit. The large box represents 1,000 people over the age of 15. The next box in, sort of the sky blue line, represents 560 people out of that 1,000 that have one or more chronic diseases. So we're over the 50% of the adult population having a chronic disease. The next line in represents the 238 people within that population of 1,000 who will contact their family physician in any given month. In the bottom corner, the dark blue square, it's not proportional, but that dark blue square represents the 8 people out of that 1,000 who will have an overnight stay in hospital in any given month. So in Ontario, we have the Excellent Care for All Act that was referenced earlier today, but it currently applies only to the hospital sector, 8 of the 1,000, rather than 238 of the 1,000 of our population. And I think if we're serious about the notion of excellent care for all, we really need to be having the conversation about excellence in primary care. But outcome measurement in primary care is actually a difficult thing to do. And part of the reason for that is that the lower the acuity of the presentation, the lower the system ability to influence the outcome. The higher the acuity, the higher the system influence over the outcome. So if I roll into a hospital having a heart attack, as long as I don't get up off that stretcher, my outcome will depend largely on the way in which the system responds to me. Everything that led up to the point where I had that heart attack depends largely on my choices, my family context, my community, perhaps to some extent my access to primary care. But all of those decisions that I make are largely outside of the ability of primary care to influence, although in many instances we can have some influence. But if we're going to talk about health outcomes, we need to be able to have the conversation about outcomes as a whole system approach. So how then does primary care deliver value? I think this is an important thing for us to wrap our minds around as we think about what it is that we need to ask of primary care. So primary care is an integrator in the system. It is the point of entry to the healthcare system for most people. It is also the point of return. So people enter the system, they may be referred out for diagnostic imaging or lab tests or to a specialist, and they return to the primary care provider for coordination of that care. That is a fundamental responsibility of primary care. We also know that we expect primary care to deliver comprehensive care. People set that bar slightly differently. One of my colleagues will say, I expect that I can provide 90% of the care that 90% of my patients need. That's a pretty high bar. Other people will set it slightly lower. 80% of the problems of 80% of my patients I should be able to deal with in primary care. Wherever you set the number, the point is that primary care adds value by being able to deal with the majority of the problems of the majority of the patients in that practice population. And it adds value by continuity of relationships over time. It is in the context of relationships that primary care can help people to prioritize, as I think Danielle had referenced earlier today, those people with multiple problems who come in, who need a place where they can try and prioritize their care choices and their goals of care. And that's a fundamental responsibility of primary care, and it happens in the context of relationships. It's also through that continuity of relationship that primary care can influence behavior and influence disease risk, and in that way, primary care creates a link to public health. I hope this one's mine. So to turn now then for a moment to the current context for governance and practice improvement in the province of Ontario. This comes a little bit to the physician funding models that were touched on earlier today. We have several different models for funding physicians in the province of Ontario. The first and most sort of historically well known is the fee-for-service model. There is a patient-provider accountability, but many documents will say, in that model, physicians are only accountable for the services for which they are paid. Full stop. Physicians take on their accountability to patients in different ways. In Ontario, then, there is the FIN, FIG, and FO model. These are models that cluster physicians together, and they do have governance agreements. There are governance mechanisms, but it's governance for management issues, scheduling for after-hours care, how to enroll patients, and funding distributions within that group context. The RNPGA is a model that funds 33 communities in the province of Ontario, and it funds whole medical services. I work in an RNPGA community, and in my contract, my group and I are responsible for all care provision, hospital emerge, inpatient palliation, and all primary care services, 24 hours a day, 365 days a week. And the difference in the governance of this model compared to the FIN, FIG, and FO is that we are responsible for the whole of the population in the postal codes that we serve. We do go through the process of enrolling patients, but we actually can't refuse a patient. If a patient is in our catchment, they are our patient. Family health teams, CHCs, and AHACs really are the models that have governance for quality. They're the only models with governance for quality. So those are the practice models through which physicians are funded, but there are some local initiatives, and I think facilitated change was the language that was used earlier today, and Andrew spoke to Health Links. I won't add anything on that. But rural health hubs is a conversation that's evolving in several rural communities that looks at how we bring together all health providers within that fairly local, it's not really a regional area, fairly local area. So hospital sector, primary care, mental health and addictions, sometimes paramedic services, home care services, and brings them together either under an aligned governance mechanism so that we are aiming at the same indicators, aiming at the same outcomes, or under a single governance structure. Some of that's being piloted in Ontario now, and I think that will be an interesting initiative for us to watch from a primary care perspective. And then certainly there are many intersector projects that are unfolding in more of an ad hoc way with sort of a steering committee level kind of governance. But those projects are evolving because I think people do want to see change. They can identify ways in which we can do better for our patients, and this is one of the mechanisms through which we can do that. But I think in some ways this is kind of where we're at in terms of the culture of transformation in Ontario, and for those of you who can't read the slide, it says, "I'm hoping that you'll lead us on a journey of transformation without requiring any real changes." And I included this slide because I think family physicians really do identify the ways in which we can see the potential for change. We know the things that need to be better in the system. So we'd like to have some of those pieces of transformation, but doing the work to get from where we are to where we'd like to be is a challenge, and identifying the resources to support that work is also a challenge. So if we do move forward with practice improvement and in partnership for results, how might we do that? I'll just start by reminding us that 75% of physicians work in models that don't have a governance for quality currently. And I think Andrew responded to the question earlier today that part of the change that we'll see will come from the process of just building momentum. There will be practices that shift. Patients will begin to ask their own providers why something's happening in that practice over there and it's not happening in this practice over here. And so there will be some change that will happen through that mechanism. But we also have an opportunity to advance practice improvement in a step-by-step approach, sort of the incremental change that Stephen Samus referred to earlier. OCFP has done some work with HQO that really looked at what are the pieces of that we need, and we need to look at how we strengthen leadership for improvement and system change, how we enhance education and support in a practice context in order to support practice improvement and quality, and how we can facilitate the team use of data. That's certainly an issue that's come up over and over again. But if we can find ways of supporting this, that will help support the how of change, how we get to where we want to be. And then there's the what of change. What else do we need to support a culture of improvement in Ontario? We need a shared language of governance, including a language around accountability and leadership, and that will help support a culture of improvement. We need practice support and tools and coaching. Actually, practice-based coaching for improvement is something that many physicians feel would be of benefit to them as they move along in their learning trajectory around improving the system in which they work. And those kinds of things can help to build capacity. We need an equitable approach to health human resources. Some of the challenges of equity of access are really because we don't have the resources where we need them. And really, we're working in a province currently that doesn't have a strong approach to health human resources and how we do that. That's certainly a need, and it's an easily identifiable need in my region. We need a whole-of-system approach to primary care. We talk about the change that we need to see within primary care, but part of what primary care providers need is a responsiveness from the rest of the system in order to support us in the work that we do. We need excellent data, and I'm going to apologize for having said interoperable systems. We need one system, sorry, Tom, in order to help support some of the evidence-informed decisions. And we need to involve clinicians in the planning and design with a focus on patient care. When we speak to physicians about improving patient care, they quite quickly come on board with many of the initiatives that people are proposing. Patient care matters to physicians. We also need to agree on the layers. I won't go through this slide in detail. It's been referenced earlier today, but the micro, the meso, and the macro, we need to agree about what it is that we expect in primary care at each of those layers. And I think Tom may have left the room, but this is my shout out about the patient medical home model. The patient medical home model is a model through which primary care can be very effectively delivered. It was a model developed, as far as I know, in the States, certainly introduced in the States several years ago, introduced formally in Canada in 2011 by the CFPC, the National College of Family Physicians. It has 10 pillars. I've included 9, which are directed at patient care and quality improvement. The 10th is really around how we use patient medical homes as teaching resources. But you can see in this several of the things that we need of primary care and that the system needs primary care to deliver. A patient-centered approach. Every patient has an attachment to a family physician. Access is timely, care is provided in teams, it's comprehensive and coordinated, there's continuity of care in the context of relationships with continuity of information as well. With EMRs, with data that support decisions and evidence-based care, there's a focus on QI, and there are strong internal and external supports, including governance mechanisms. This model aligns very well, I think, with the health system culture of quality. I've included this slide, which is a quote from a man named Chris Ham, who works with the NHS and has written a paper called Place-Based Systems of Care. And I'll read it to you in case you can't see it yourself. System leadership that is not underpinned by clinical leadership and the engagement of frontline clinical teams will not deliver the benefits that we have long argued for. And so this is really a call to include clinicians in the design of systems and in the governance work. And I want to leave you with an analogy, and it really is the analogy of the territory and the map. So Dr. Ian McWhinney was the father of family medicine in Canada. He talked about the map and the territory of family medicine, and when he did, he was referring to illness and disease. But as Daniel Martin and others have pointed out, it really is a lovely analogy for the process of clinical care and systems thinking, or in this instance, clinical governance. So the analogy is this. As family physicians and primary care providers, when we are working with our patients every day, in our clinics, in our hospitals, in their homes, we are moving in the territory of primary care. And right now we're doing it, sort of with our eye on the horizon, not really any good map. We're trying to find our way around that big hill rather than try and find a way over it. Good clinical governance can create the kind of map that can allow people to move through the territory of primary care much more easily, and that, after all, is the intention of any good map. And I'm going to take that analogy one step farther and just say, I don't know if any of you have ever done a backcountry trip with a brand new Parks Canada map or a brand new Ministry of Natural Resources map. Those maps are great. The topography is excellent. The detail is good. But a brand new map is not nearly as good as a map that has been used by somebody who has already traveled in that territory. And they have marked the best sites and the best fishing and noted where you can take the portage, don't run the rapids. But the point of that is simply to say that the best maps and the richest maps are the ones that have been deeply informed by the people who are the most familiar, not just with the topography, but with the territory. I'll close there. Thank you.